Afternoon, everyone. Welcome to yet another episode of Genomics Gupshup, and I'm very excited because today we have our own Vaishnavi Suresh, who's a genetic counselor at MapmyGenome, and she's going to be able to help us understand a lot of the tests that are required when you are going through a pregnancy, especially potentially a high-risk one. So, welcome Vaishnavi to Genomics Gupshup, and I hope you will enlighten all of us about all the things about fetal medicine.
Yeah, excited to be on this episode.
So let's move on to why you became a genetic counselor. What was your motivation? Who inspired you to become a genetic counselor?
So I was somebody who was always patient driven and patient oriented. I aspired to be a doctor, but that couldn't happen. So I did my bachelor's in biotechnology, zoology, and chemistry. So there was this one particular topic that spoke about genetic counseling. That's when I came to know that this is something that I am interested in. So I wanted to do a 1 year PG diploma proper specialization course, but then I was not eligible at that time because I only had 3 years master's degree. So I did a 2 years master's in human genetics and molecular biology, and then I gave my entrance in Kamineni, and that's how I became a genetic counselor. Genetic counseling is something that I've always been passionate about since my degree time. So being patient driven and patient oriented, this is what I wanted to do, and I chose this field.
So you're also very patient.
Yes.
Patient.
Yes.
And you look at patients.
Yes. So there's a saying that a genetic counselor usually follow: be empathetic but not sympathetic.
That's amazing. Be empathetic and not sympathetic.
Yeah.
That's fabulous.
So you put your feet in their shoes and understand what they're going through, but don't feel sorry for them. So you should have that emotional connect also, but not too much. So you should understand what they're going through and provide them a non-directive counseling, so that you are not somebody who has to take part in decision making, but give them options, that this is what these are the testing options. It's up to you. No matter what you choose, we are there for you.
So you're there as a guide, but we're not telling you pick this option, pick
Correct.
that option. That's between the doctor and
the patient. Correct.
So what exactly is fetal medicine?
So fetal medicine is basically, the obstetricians and gynecologists who have done a 3 years extra course, especially in high risk pregnancies. So they'll be able to identify women who are potentially at high risk of developing preeclampsia or any chromosomal or genetic diseases or disorders. So that is their specialization.
So there are lots of I was reading through your blog and I think maybe it will help in understanding what is perinatal, what is antenatal, and all these different terms that are there. So because for a lot of people, I think they get confused with what exactly is perinatal. Why is it that a fetal medicine doctor is also called a perinatologist, right?
Yeah.
So what does peri mean? Is it just before pregnancy, or what does peri mean? Just before birth, or is it something else?
Okay, perinatologist and antenatal both means the same. So your antenatal, prenatal, perinatal, all of this are your this one and the same terms.
So you told us that these fetal medicine doctors are basically gynecologists or obstetricians who basically have an advanced degree
Yes.
in being able to understand high risk pregnancies and all of that, right? Now, one of the things that people get confused is there are lots of things that work with the word natal, right, which basically means birth.
Birth.
So what exactly is perinatal? What is prenatal? What is antenatal? Right? Pre will be before, right?
Yes.
I'm assuming, and then peri is during.
During.
And anti is also during.
During.
Okay.
So all the three terms means one and the same. You're checking the position of your baby, the health of your baby, if there are any structural, abnormalities in the fetus, along with care for the mother.
So that's the role that the fetal medicine.
Doing. Yes.
And what are the tools that they typically use, right? I mean, in terms of tools, I mean, what kind of, the whole blog is about a lot of the different tests. So is it that the fetal medicine doctor is going to use a lot of different tests? Or is it also, do they just look at someone and figure it out? Or how does it all work, right? I think That is something I'm curious about.
Okay. So, to begin with, like you said, they also do ultrasound testings. That is your transvaginal. First is the transvaginal scan that a fetal medicine specialist does to check for the position of the fetus, whether the pregnancy has occurred in the right place, that is in the uterus, because sometimes pregnancy can also happen in the fallopian tube. That is your false pregnancy or ectopic. Correct, your ectopic pregnancy. So that is the first scan that a fetal medicine does. That is transvaginal. The rest of the scans are your abdominal scans. So coming to the next one, it is your.
But before we get there, how do people know they're pregnant? I mean, I know how to figure that out, but maybe it would be helpful to understand how people first figure it out, and then the scan that you just mentioned is where they actually confirm it, or there's something else.
Okay, so the first and the common symptom that you're pregnant is your missed period or your menstrual cycle. However, in a few women, they experience nausea, vomiting, dizziness, and all of this. So once you skip your period, the first testing that a woman needs to undergo is your home kit pregnancy test to confirm. Or if they do not want to go with the home kit, because many of them prefer going to the hospital and getting their beta HCG levels checked. So once that, either you can do home kit or beta HCG level. So once that's done, next comes your transvaginal scan, that is at 4 to 6 weeks, to check the position of the fetus and to check the heart rate.
Okay.
This is the early detection of your pregnancy.
So you checking HCG is basically then a marker that helps us understand if a woman is pregnant or not.
Correct.
It's a protein that helps us understand.
Correct. It's a biomarker.
So you've now figured out that you're pregnant. You've got a scan that said that yes, you are pregnant. Then what happens?
So next comes your NT scan and double marker test that happens at 11 to 13.6 weeks. This is called as combined first trimester screening. So in this, the fetal medicine basically checks for the level of NT that is behind the neck, that is called as nuchal translucency. NT is basically called as nuchal translucency. They check for the level of NT. So if it is beyond 2 mm or 2.2 mm, then there could possibly be a chromosomal aneuploidy in the fetus. This is, however, just a screening test. Coming to your double marker checks for two biomarkers, that is your HCG and PAPA levels. And then a risk estimation is done on either life cycle or Astrea platform. And the woman gets a report that says that 1 in so many, 1 in 50, 1 in 100, 1 in 1 lakh for trisomy 13, 18, 21. That is your Patau, Edward and Down syndrome respectively.
So when you mention the word aneuploidy, right, that basically means a chromosomal defect, right? So what does ploidy means? The multiples of it.
Yeah. So aneuploidy. So it could either be monosomy or trisomy. So every human being has 46 set of chromosomes, 23 pairs basically. 23 is inherited from the mother, 23 is inherited from the father. That is 46. So if there is more than 46 chromosomes, then it is like 47 or something, then it is trisomy. If it is less, that is 45, then it is monosomy. This can happen at any chromosome level, chromosome 1, 2, 3, 4, 5, 6. We basically check only for 13, 18, 21 because only if a baby has trisomy 13, 18, 21, the baby can survive up to term. If there is trisomy in any other chromosome, 1, 2, 3, 4 or 5, it usually ends up as a miscarriage in 5 weeks, 6 weeks. So that is why we basically check for only 13, 18 and 21. In spite of them having a defect, they grow up to term.
So nature automatically takes care of in some ways,
yes.
and therefore we never see those babies
correct
become into real human beings.
Correct.
So the ones that we need to be worried about would be 13, 18
and 21. And monosomies, usually it is your Turner syndrome, that is XO.
And then you mentioned another test, right? After that, what happens? You mentioned a double marker test, which was your NT and these two proteins we checked. Then you mentioned a quadruple marker test.
Correct.
What does that do?
So quadruple marker is again a screening test where you check for 4 biomarkers. That is your beta HCG, estradiol, inhibin A, and alpha fetoprotein. So when these levels increase or decrease based on the levels, you can the risk estimation is done again, same on either life cycle or Astrea platform, and the risk is estimated 1 in so many. So here we are also looking at your neural tube defects along with your trisomies. So neural tube defects can again be detected in your NT scan as well. So when they do the NT scan, you can see if there is any open, that is your spina bifida, meningocele, and all of this can also be detected during your NT scan as well.
And so neural tube defects, which are basically defects where you can, your spinal cord is not well developed, right?
Yeah.
So what are some examples? How does a baby, if someone's born with a neural tube defect, what kinds of, are there any examples of?
One of the most common example is your anencephaly, your spina bifida, meningocele. These are the very most common types of neural tube defects that we can often see.
Okay.
Yeah.
And then you've given a nice chart in the blog which sort of explains if it is if your AFP is decreased in all of them, then your neural tube defects are likely to be there, right?
Yeah.
So it's sort of a screening that you're
It's
saying.
like, it's a lot of screening. So when all the levels are decreased, which means it's an indicator of trisomy 18, that is Edwards syndrome. One level is increased, just your alpha fetoprotein level is increased and other levels are normal, which means that there is a risk of the baby having neural tube defect. So these are again your risk estimation. We are not confirming you or diagnosing you of that the baby might have. We are just telling you that these are just the screening tests and not the diagnostic or confirmatory tests.
So basically we look at the chart and then, like you mentioned, there's AFP is decreased in all of these four, if you look at it.
Yeah.
When all these are decreased, then you're saying your neural tube defects are
No,
increased.
you have to basically look it in the vertical way. So when your AFP is decreased, your estradiol is decreased, and your HCG and inhibin A are increased, it's indicative of trisomy 21.
Sure.
And when your AFP, estradiol, HCG, and inhibin A, all of them are decreased, then it's indicative of trisomy 18. So look at in this way and not in this.
Sure.
Yeah.
So basically, you're looking at the markers and you're looking at the results, and then you're saying that if your AFP is decreased, your estradiol, and your HCG is increased, and your inhibin is increased.
Yeah.
Then that shows a trisomy.
High risk of the child having trisomy 21, that is your Down syndrome.
Okay. And so you basically look at all of these markers and then look at the chart that Vaishnavi has nicely indicated in the blog, and then you'll be able to see if there is a risk. Now, of course, this would be dependent on what the fetal medicine doctor would finally tell us and what the risk estimation is from your machine.
Correct.
Okay.
Also, this is again related to the age of women. Usually what we say is women beyond the age of 35 are as high, they fall under high risk. However, when the software, when it reads based on the age group as well. So if she's 25, so the risk estimation is done based on her age and the population.
Got it.
So that is how the risk estimation software and the risk assessment is done.
Yeah, I remember I had 2 pregnancies. The first one was when I was in my 20s, the second in my 30s. And there were clearly a difference in terms of what tests were prescribed to me at that point of time. And of course, the difference was also that the first one was in the US, the second was over here. So clearly, maybe there are some differences in terms of how they categorize a mother as potentially high risk.
Right.
Okay. Then you've also mentioned a lot about different types of screening tests and different kinds of actual diagnostic tests, right?
Correct.
So which ones are the screening tests? What exactly is an NIPT test? I think this is now a term that like a lot of people have heard about. I think
Correct.
the first most common thing that people call me when they have a baby is saying, I need to do an NIPT test. Now, what exactly is an NIPT test and how is it done?
So NIPT is also known as NIPS, that is your non-invasive prenatal testing or screening. As the name suggests, it's just a screening test and not the confirmatory test. However, the sensitivity and specificity for NIPS is higher than your marker tests. the sensitivity and specificity for your double marker is 87 to 90%. For your quadruple marker, it is 85 to 87%. But for NIPS, the sensitivity and specificity for trisomy 21 is almost 99%. For your trisomy 13 and 18, it is about 93 to 95%. And for your sex chromosomes, it is 85 to 90%. So NIPS is basically your cell-free DNA testing. A lot of women, they are scared to go in for an invasive test if there is a high risk on marker. So your double marker or quadruple marker is indicative of high risk for trisomy 21 or 13 or 18. So a lot of women, they are scared to undergo invasive testing, that is your chorionic villus sampling or amniocentesis. So for those women, we can offer NIPS, but while counseling, we have to tell them that this is just your screening test and not your confirmatory test. If NIPS picks up a high risk for any of these, they have to definitely go in for an invasive test.
But if they get a clear or a negative, then they don't.
They don't have to go in for an invasive test.
And what is this mention, the TIFA?
Okay, TIFA is basically your targeted imaging for fetal anomalies or aneuploidies. So it is a head-to-toe examination of the fetus. They'll check how the brain is, how the baby's hand is, how the feet is, how is the heart, is there any hole in the heart, commonly called as ASD or VSD, and how is the liver of the baby. So if there is any structural deformity in the fetus, it can be picked up by this TIFA scan. It is usually done from 20 to 24 weeks. However, a lot of fetal medicine specialists offer it around 18 to 19 weeks, because if there is any structural rearrangement, they can go in for an amniocentesis around 18th week and get a diagnostic test done.
You mentioned both CVS and amniocentesis. Are these also screening tests, or these are actually diagnostic tests, right?
These are diagnostic tests. So chorionic villus sampling, commonly known as CVS, is done between 10 to 12 weeks of your gestation. So it is either done by trans-abdominal or trans-vaginal. So the small part of tissue is scraped out and done for the testing. A lot of doctors and fetal medicine specialists do not opt for CVS because the rate of placental mosaicism, that is when you're doing a karyotype or something, there's something called as mosaicism that is associated. So a lot of fetal medicine or genetic counselors do not prefer CVS. However, if there is a clear-cut testing, that is if both the parents are thalassemia minors and they have a child who's affected with thalassemia, and they want to know what is the risk of the next child having thalassemia, they can go in for CVS. But if there is no clear-cut diagnosis, especially in India, we see a lot of consanguineous and endogamous marriages, and there is a lot of autosomal recessive conditions that run. And many times what happens is patients do not realize it, and when they come to a fetal medicine specialist, by then they're already 15 or 16 weeks pregnant, and they tell, we had a previous child who was affected and he or she has passed away. What do we do now? In such cases, we can offer a trio-exome sequencing, wherein we are testing for both the parents along with the baby. That is, for that we can usually advise amniocentesis. Amniocentesis is again, first they see the fetus's position and fetus's movement and everything. It's basically done under ultrasound guidance. For both CVS and amniocentesis, it's an ultrasound guided procedure. Amniocentesis is preferred more than CVS because the baby is grown. Just like how the fish moves in a bowl in an aquarium, the baby moves in the womb. So once the baby is on this side, a small syringe is inserted from the opposite side, and 20 ml of amniotic fluid is taken and the testing is done. The risk for both is less than 1 to 2%, but we have to tell them that this is what the risk is.
So you now done the amniocentesis, you can diagnose whether that problem is existing or not. Now, while you were saying all this, I was thinking that you mentioned things like thalassemia and all. Now I do understand that you mentioned the cases where people already had a baby, but for a lot of parents, can't they do a carrier screen upfront before they even plan a baby? Because I think that sort of gives them the possibility of what likelihood is there for the child to have if any, in terms of genetic disorders, right? I mean, assuming that they didn't have any financial problems, right? Do you think that would be something that they could consider doing a carrier screen? Because we talked a lot about genetic disorders and many of them, and most of them seem to be more structural disorders. But at least with the carrier screen, maybe you can even find out more about other disorders like your thalassemia and all that. So do you, of course, you're not expected to give an opinion, but I'm just thinking as somebody who's, I wish I had that option. Not that my children turned out to be fine, but it would be nice to see that from a parent's perspective.
Correct. So like you said, we can offer them couple carrier screening if they come for a premarital counseling or after they, preconception counseling. So for both of this, they can come in for a pre-test genetic counseling, and we can offer them couple karyotype and couple carrier screening, because a lot many times what happens is, especially in South India, you see a lot of consanguineous marriage. However, consanguinity and endogamy is present everywhere, in every part of our country. So if they really want to know what is the risk of both of them being a carrier for any autosomal recessive condition, why not? We can offer them upfront a couple carrier screening.
So Vaishnavi, we've gone through all of the different kinds of tests and everything. Some of them were the double marker, then you had the quadruple marker, you had NIPS, and then you had the diagnostic test, right? The CVS, and then you had amniocentesis. So there are so many different tests, right? When do people come to see a genetic counselor during this whole process of when they are having a baby?
So usually most of the genetic counseling sessions happen when there is a reference from the doctor. So the fetal medicine is the one who realizes when should a patient meet a genetic counselor. If the fetal medicine feels that they have to come in for counseling when they have a high risk on double marker or quadruple marker, they can come to us for counseling. Or if there is any high risk picked up on NIPS, saying they have picked up a high risk for trisomy 21, what should they do next? So that time they can come in for counseling. So in genetic counseling, it's basically divided into two parts. One is the pre-test genetic counseling and the other is the post-test. So in pre-test, we take a 3-generation family history to understand if there is any genetic disease or disorder. Followed by, we'll explain them what the double marker, quadruple marker or NIPS says. Because a lot of times we get questions wherein they say that we already underwent a test and they come to a conclusion that the fetus is affected. So in such cases, a counselor plays a very important role to make them understand that these are just your screening tests. We are not diagnosing or confirming that the fetus has this chromosomal disorder. So in pre-test, we'll take a complete family history, advise them for certain tests like karyotyping, FISH, QFPCR, microarray, exome sequencing, all of these testings. And post-test is when the couple or the woman undergoes a testing, and post-test we explain them what the test report says. Most of the times, even if there is a high risk picked up, the confirmatory test comes out to be normal. However, there are chances that what the screening test says, it will match with your confirmatory test. So we have to make them understand. So we are genetic counseling is basically non-directive counseling. So we do not direct a patient saying, अगर आपको ये है, if there is trisomy 21 picked up on karyotype, we do not tell them this is what you should do. We give them options. If they want to continue the pregnancy, we tell them about what the condition is, how can it be managed, and then we refer them back to the fetal medicine again. So the final decision happens between the doctor and the patient. We put all kind of options on the plate and we serve them. It's up to them what they need to pick up, and then they can go ahead with that.
So they understand the probability, but they also understand what is likely to happen. You're giving them all of that.
All the options and all. If they want to continue with the child who is having Down syndrome, we explain them. These are the symptoms. They could be, delay in development, that is milestones delay. There could be hypothyroidism, low IQ. So all of these we would tell them prior to they, continue. And then we give them, whatever options it is, we tell them, and then they can go back to the referring clinician and take the decision.
So you have two different kinds of counseling, right? The one that before and then one that
Correct.
is
Correct. So in post-test genetic counseling, we'll be explaining them that because before we confirm that whether the fetus has that condition or not, it's not right for a counselor to tell all the symptoms and everything, because it only scares a patient. It only puts them in a very confused state of mind. So if the fetus is completely normal, why should they go in for a termination? They can continue with the pregnancy. So this is something that everybody needs to understand, that although there is a high risk in NIPS, it's still a screening test and not a confirmatory test.
And then when do you recommend these other, like a lot of the other tests that you mentioned, right? There's MLPA, QFPCR, exome sequencing and all of that. When do those come into the picture?
So your karyotyping, FISH, QFPCR, microarray, these all look at a chromosome level. So if there is any monosomy, that is one chromosome less, trisomy, one chromosome more, or if there is any translocation, or if there is any microdeletion or microduplication. In such conditions at a chromosome level, these tests can be offered. But if you want to look specifically at a genetic level, then they have to go in for exome sequencing or Sanger sequencing. So I basically came up with this simple way of counseling to my patients. What I tell them is, imagine your body as a book. Your chromosome are your pages. So every human being will have 46 chromosomes. So every book will have only 46 pages. So all these testings are at your page level. So if you want to go in depth, that is those words, if there are any changes in those words, then you have to go in for an exome sequencing or Sanger sequencing. So if there's already a mutation identified, Sanger sequencing, that is your targeted. But if the mutation is not identified, there's already a previous child who was affected and who has passed away, or if that proband is still there. So depending on that, exome sequencing will be advised. Trio-exome sequencing and all of that.
So maybe it will be helpful to clarify what a proband means.
Proband is basically the person, if suppose a pregnant woman comes to you, the pregnant woman and your child becomes your proband. So that you're basically looking at we usually, since the child is unborn, we cannot call it as proband. However, we include both of them as the proband level, because even when we're using invasive testing, so even the woman is at a risk. So we include both of them as proband. Mostly it is the person who comes to you for counseling was affected with the condition. That person is a proband.
So a lot of times, people want to do something in genetics, right? It's a new field. Everybody's excited about it. What would you advise a lot of the young students who are currently pursuing, either they are in their 11th, 12th, or in their bachelor's? Since you have now become a genetic counselor, is this something you would recommend to them, or and if so, why?
So I get a lot of queries on my LinkedIn and Instagram telling that they're very passionate about this field. What should they do? How should they go about? I only tell them one thing. If you are patient driven, this is something that you should take up. In India, genetic counseling is still a growing and a booming field. Unlike other countries like the US, Australia, New Zealand, UK, where genetic counselors are recognized and everybody knows the importance of a genetic counselor in genetic testing. But that is something that we still lack. The awareness that is there amongst the general population is something that we have to create. So we are also not just genetic counselors, we are also policy makers. So we should involve ourselves in policy making. We have to bring out new policies. So as genetic counselor, we have to be, very much involved in all of these. So all those students, all those who aspire to be a genetic counselor, this is a right time for you, because down the lane in another 10 or 15 years, genetic counseling will be recognized and a lot of doctors, patients, everybody will understand the importance of genetic counseling. Especially in India, as I already mentioned, consanguinity and endogamy is something that is, a lot. So for such patients, they do require a genetic testing and they should undergo a genetic counseling process for them to understand better.
So is there anything else that you would like to tell our viewers?
Yeah, so what I would like to add is we are here a team of genetic counselors who are here for you. So if you have, if you feel that you do need genetic counseling, please do reach out to us. We are a team of about 7 or 8 now. So if you feel that you do need counseling, so genetic counseling is not just family history and genetic counseling. We also give you psychological and psychosocial counseling. If you feel that you do need, be it premarital, preconception, or prenatal, or if you have any family history of cancer, please do reach out to us. We are here to help you. So, as I already mentioned, genetic counseling is something that is still growing and booming, unlike other countries. So, what I would advise the young generation is, just because you do not get seat in medicine, if you do not clear NEET, don't be heartbroken. It's okay, it happens. If you're somebody who's patient oriented, patient driven, there are so many other courses. Genetic counseling is something, if you love genetics, if you love patient interaction, you should take it up. Yeah, that's it.
That's great. So
Yeah.
thank you, Vaishnavi. Very lively and interesting interaction. I think, especially on a difficult subject like fetal medicine. So thanks and all the best.
Thank you.